we know that a lot of primary care providers are already seeing patients, and that with COVID, the increase in mental health concerns across all ages, not just in children, has gone up from 20% across the board to rates of anxiety and depression doubling and tripling. And there's often a significant lag time between the onset of symptoms and the time to diagnosis. And that primary care providers are already delivering a lot of this care, and that it really offers the ability to provide care in an integrated, accessible, and low stigma setting. And the medical home is something that is not a new concept at all, and has these wonderful qualities of being accessible, continuous, comprehensive, family-centered, coordinated, and compassionate, and intended to be culturally effective, and that it is accessible and also not limited by insurance. And we really want to think about workforce development within the medical home in this stepped care approach, where primary care providers provide a lot of treatment to many. And then up at the top at number 5 in this pyramid, that specialists see the more acute and complicated presentations in more traditional models of care. And then these steps in between, primary care providers can receive some consultation from mental health specialists. And so e-consults would be in this number 2 category right here. And in terms of, being able to do this, this was from a book on integrated care. And these are some thoughts from focus groups beforehand. This is going to slow me down. I don't have time to address one more thing. I already do a good job of treating mental illness. This is going to drag me down like an anchor. And then afterwards, after really developing kind of better illness scripts for recognizing and addressing these conditions, this is, it takes a load off my plate. It really speeds me up. I always want to practice like this. And in terms of the continuum of behavioral health integration, so this is technological applications, and kind of on the lower end, we have patient-facing technology here in these categories. And then here we think about e-consults as really building capacity to treat mild to moderate behavioral health conditions. I acknowledge that the mild to moderate, moniker is scheduled to go away, and we know that nothing is really mild, especially right now, but e-consults are here, and this allows for primary care providers to really build skills and address more problems. And then a collaborative care model is something that can either be done through remote telehealth consultation or integrated within the practice and co-located. So we talked about this this patient, and so in terms of my initial thoughts on this, there are a lot of concerning symptoms here, right? And it really sounds like he's experienced a lot of trauma, both with the sexual abuse that happened with his peers, and then even more remotely, the separation from his father, his paternal aunt. And also, we don't know when he was separated from his mother, and we don't know if there was other abuse. So thinking about, what does aggression look like? And, that behavior is what we see on the surface, but beneath the surface, there are all kinds of thoughts, feelings, and expectations, and kind of deeper sense of self and identity. And that many times what we see on the surface as being anger can be a lot of other emotions, many of them that are anxiety or fear-based, or sometimes physical, being exhausted, feeling lonely, feeling insecure, feeling a lot of grief. So I think this is one of my favorite expressions by a colleague that I often quote and borrow: be curious before you get furious. So asking more questions, what is going on, rather than immediately reacting to anger with more anger. And in terms of developmental responses to trauma, we know that this can evoke a lot of different really normal feelings and behaviors. And so in younger children, they may have increased fear of separation. They may be more irritable, crying, screaming, not eating well, and also having nightmares that may be nonspecific. And then in elementary school age children, like this boy, they may be more anxious or fearful. They may have guilt or shame and have a hard time concentrating and difficulty sleeping, and also potentially acting out in terms of aggression, especially if there is some comorbid expressive language difficulty, because if we can name our emotions, if we can express them verbally, then we don't need to act them out. But in kids who have a hard time with expressive language, or who may not fully comprehend what's happened, then feelings can come out in behaviors. And then in middle school and high school age children, there can be concern for feeling more depressed, alone, isolating, having other ways of trying to self-regulate that include self-injury, or maybe developing an eating disorder, abusing substances, and taking risks sexually. And so this is from Adverse Childhood Experiences, ACEs Aware website. These are, the significant number of both physical and emotional concerns that are much more likely if you have higher ACEs scores. And so we won't go into all of these, but I'm happy to share these slides afterwards. But you can see that there are a number of physical concerns, as well as some of the things that we're seeing here: sleep disturbances, developmental delays to learning and behavior problems, and here aggression, as well as ADHD and suicidality. And so when we think about a strengths-based approach, this may be something that you're already, wholeheartedly embracing in your practice, but it's sometimes can be hard to define what is trauma-informed care, but it really starts with conceptualizing things as, going from what is wrong with you to what happened to you, and then taking it a step further and really embracing a strengths-based approach, what is right with you. And so it can be really, we're taught to give diagnoses, we're taught in some ways to pathologize so that we can identify problems and develop a treatment plan. But I think it's very important to understand and be curious and consider what's going on for this youth and for all of our patients. And in terms of, what is in a primary care provider's skill set and toolkit, I just want to pause and think about not only medications, but also the importance of connection and validation and being able to give guidance. This is a pediatric case, so thinking about the AP recommendations on positive parenting, anticipatory guidance, and also trauma education. And so here, these could be some ones to really focus on. And in terms of thinking about an overall treatment plan, we want to think about, what is really going on, how acute is this problem, and then what do I need to do? And so in the kind of less severe category, counseling might be in order, and really thinking about these kind of lower level interventions that are more relational. So establishing relationship by noticing strengths in relationships. And then the O is offering science through anticipatory guidance and positive parenting. The T is for tools on trauma education. And the E is for empowerment, looking at what are the ways that you can capitalize on those strengths, because really health is what happens in between office visits, ideally. And then in this next category here, this is more concerning symptoms, and thinking about what are the basic needs. Could there be any community resources to consider for a lot of youth, like a Big Brother, Big Sister program or a similar program in your community? Are there any other specialists that you need to enlist, including medical, mental health, and substance use? And then what are some parenting resources and some stress mitigation interventions? And then in the more severe end, there may be reasons to enlist community crisis or 911 if there's concerns for danger to self or danger to others or threat to safety. And this is kind of the continuum of care of considerations. This is adapted from the American Academy of Pediatrics continuum of care. And we really like to think about, all the different systems and services that might interact with a youth. And so what is happening within the medical home. And, this is going from kind of most more limited intervention at the top, and then going down to more severe interventions. What are the community, interventions that may be needed? And then what are the school-based interventions that can happen similarly with regional center when that is indicated, and then also specialty mental health. And so again, I just really want to applaud the level of validated rating tools that were already obtained for this patient. And this is consistent with thinking about a measurement-based treatment to target approach that is really critical in being able to not only properly diagnose conditions, but also be able to track symptoms over time and know when things are getting better. And so ideally, this is part of a treatment plan that's developed by the care team, which may just be one person, but ideally would be other, treatment team members like a therapist and care coordinator if you have one. But the goals really have observable and measurable outcomes, and that these are routinely measured. And in a recent review article, it was found that the most effective way to do measurement-based care is if you are routinely assessing it, not just intermittently or not just haphazardly, and that you are actually reviewing it in real time with the patients, because they like to see their symptoms improve. And then it offers an opportunity when you review it, for example, with the PHQ-9 to ask about, okay, you said that you're not sleeping well. And it says, too little sleep or too much sleep. And so you can ask a little bit more about what that means. But people really like to see that they're making progress. And this also then justifies, if your PHQ-9 is still at a 15, we're going to increase that dose of the SSRI. And these are just kind of core principles related to collaborative care that can be applied to any type of integrated care, that it's patient-centered, that we're thinking about population-based care. So the idea that those, those specialty mental health spots, because there are so few mental health providers, are reserved for the more acute and complex presentations. And then the more time-limited or more mild to moderate conditions can be managed within primary care. And that we're doing that treatment to target dosing, and that the care is evidence-based. So for this patient, this is part of my response. I had said that, diagnostically, I'm wondering if he's had a psychoeducational evaluation at school to assess his learning ability, because if there are any learning disorders, then those can really amplify aggression, and whether he has an IEP or a 504. In terms of his aggressive symptoms, these are obviously the most concerning to probably everyone. And it's important to think about whether this is completely impulsive and non-discriminatory. Thinking about ADHD and the kid throwing pencils, and then, somebody says, don't do that, and they say, I didn't. And it's just an impulsive kind of sensory seeking, stimulation seeking activity. There's also then more reactive in response to an event or a person. And this can also happen in ADHD, but is also seen in trauma, in particular when feeling ashamed or threatened in some way. This can be seen in anxiety, in learning problems, in sensory sensitivities and neurodevelopmental disorders, including autism. And then the more premeditated type of aggression is really concerning for more conduct disorder and an antisocial trait that is really important to understand. And so this would be, for example, we don't know the details of him harming the animal, but if this was something that was more reactive or maybe displaced, he was angry at getting in trouble and he was angry at another person and then he took it out on the dog, versus just planning secretly to do some harm to the dog would be a much more concerning type symptom. Thinking about trauma and the impact, the Child Psychiatric Symptom Scale is a free and validated assessment of PTSD in children. And because of the sensitivity and because he already has a therapist, it would be helpful to see if the therapist could administer this. And then I'm not sure if the Scared Rating Scale, which is an excellent anxiety assessment tool, that one was very low, but often if kids don't know how to name those emotions and or they want to say everything is fine, they may underreport. And so this is where being able to follow up live and in person and asking about some of those symptoms or asking some of the questions and follow up during a visit can be really helpful, because you can get a better sense if someone is actually underreporting or sometimes overreporting. And then you'd also want to consider an assessment of any sensory challenges. And this could be, physical, clothing, also sounds, any particular smells. Are there any kids that he seems to really respond to in this way in the classroom? In terms of treatment plan, would really want to think about really maximizing the stimulants, especially if his weight is on the high end for his age. It's really helpful to have basic vital signs when asking for an e-consult, because it just helps to kind of think about what are the right doses. And then some youth who, or some people who have been prenatally exposed, in particular to alcohol, but also to other substances, may require higher than expected doses to get the necessary effect. And so really to test this out a little bit more, you could do an immediate release methylphenidate and really try to work with the parents, and then just titrate up and see if you can, get some kind of response. Given his age, I wouldn't go above 30 milligrams, but that could be a starting point. And then if you're not seeing any response or change with that dose, then you could try Adderall, because many people will respond to either methylphenidate-based preparations or the amphetamine-based ones, but some individuals really respond preferentially more to one or the other. And I would say the Concerta 18 milligrams was probably not a therapeutic dose for him, especially if his weight is on the higher end. But you want to test that first with the immediate release methylphenidate. And then with anxiety, if after doing a deeper dive, if there does seem to be really significant anxiety, and this can include also more observations of, difficulty with transitions or seeming to, be fearful of new situations, new persons, then you could try a low dose of an SSRI. There are a number of kids that I've worked with who have pretty profound anger and sometimes aggression, and it's actually related to anxiety or sometimes also OCD. And then with his tics, so given that they're not adequately treated, and also given the level of aggression, you could try a very low dose of risperidone. But I also acknowledge that, this may not be within most primary care providers' comfort zones to initiate this, but this is something that even though we are much more thoughtful and appropriate about prescribing atypical antipsychotics in youth, for this particular child, given the level of aggression and severity of it, it would be something that, that I would consider. And then depending on, your comfort zone, this could be helpful. And the study that really backs this up is the Severe Childhood Aggression Study, or TSCA study, that looked at supplementing ADHD, mainstream medication with either guanfacine or risperidone, and both were found to be beneficial. And then this CVEC guidelines for monitoring is incredibly helpful at, they even give you worksheets that you can, post if you're on a paper system, or you can schedule these, but it shows all the different types of vital signs and labs that need to be done at, baseline in X number of months. And just one other thought before moving on to the next case is that, in terms of communicating with therapists, what I have really started to do is, everyone has some kind of portal. Most people are on electronic health records at this point, and I will write a note, summarizing treatment, and or like for this child, if I did want the therapist to try and do the child psychiatric symptom scale for PTSD, I would send that along in a note to the family, either electronically or in paper, and then ask them to give it to the therapist. And that way you're being very transparent with the family about what you're asking about, and they own the information, which they have access to now with open notes, regardless. And so that can be an effective way to communicate, knowing that it's hard to reach people by phone these days, and make that time for collateral. And so this next case is an older child, and this is somebody who's actually about to turn 18. So I'm hoping that this will be relevant to those of you who work with adults as well, because we'll talk about some of the indications and SSRI pearls. So this was the e-consult question. I believe Zoloft is typically indicated for treatment of social anxiety in adults. And considering that this patient is nearly an adult, would you recommend treating with Zoloft? Or considering that she's still a teen and has had some thoughts of wishing she were dead, but not an actual plan, should we stick with Prozac? And regardless, we would start with a low dose and have close follow-up with the PCP and also with the behavioral health counselor until she can start outpatient therapy. So this was a consultation performed by a colleague, and so these were the recommendations. So there's no FDA-approved option for treatment of social anxiety disorder in adolescents, and most of child and adolescent psychopharmacology is off-label and not FDA-approved because it's so hard to conduct trials in youth. Both Zoloft and Prozac are approved for OCD in adolescents, and Prozac is also approved for major depression, but it doesn't look like this patient has a diagnosis of depression. And so I typically start with sertraline or Zoloft rather than fluoxetine for patients like this, because it seems to be more calming with less incidence of activation than fluoxetine. And this patient does have a diagnosis of long-term severe constipation, and sertraline does have a greater incidence of GI adverse effects than fluoxetine, and this may be a reason to switch if the GI symptoms worsen. Another alternative is duloxetine or Cymbalta, which is FDA approved for generalized anxiety in adolescents, but it does tend to have more adverse effects and is often a difficult discontinuation syndrome. So we're going to touch on each of these components. Basically, we want to think about, as we're making a diagnosis, what is the overall kind of biological, psychological, what are the cultural factors going on? What are the social factors as we're thinking about an overall treatment plan? And of course, with medication, the place where we intervene is in the biological realm, but this is something that's important to consider. And so SSRIs have been around since early 1990s, with Prozac being the first one, and they block the presynaptic serotonin reuptake, and they are good at treating both depression and anxiety, usually with lower doses required to treat depression, and then often higher doses required to really get at any lingering anxiety. So in terms of screening tools for anxiety, the GAD-7 may be familiar to everyone here. That is a really good one that asks about the main symptoms of generalized anxiety disorder, and that's applicable for both youth and adults. And then the scared, the GAD starts at, I think, age 11, and the scared is ages 8 to 18 and asks about all of the different specific anxiety disorders and gives you subscales on these. And then the Kessler-10 is a widely used adult anxiety rating scale. And then the depression scales, the PHQ-2 and the PHQ-9 are validated ages 12 and up. And the short mood and feelings questionnaire is validated down to age 8. And then for youth, the RCADS is good ages 8 to 18. So how do we think about, overall symptom severity? There's no kind of perfect cutoff score. So these are suggested ranges to consider. And really this all needs to be kind of, governed by clinical judgment at the time. But when we think about mild depression, we think about, fairly limited or no real impairment and, some mild symptoms here in this range. And then moderate, there is some level of impairment. There may be some comorbidity, and there may be a history of suicidality. And then the PHQ-9 suggested kind of ranges in here. And then for more severe, there is clear and discernible impairment, and there may be comorbidity, and then there may be significant suicidality and or substance use. So how do we think about, treating these? Mild depression really does not respond necessarily to an SSRI. And in fact, if you're using SSRIs for more mild depression, there's always the risk of making things worse because you can have side effects and people may be intermittently adherent. And there's no proven benefit to treating mild depression with an SSRI. Instead, you want to think about setting and monitoring some treatment goals that include goals for wellness and healthy nutrition, which could be a whole nother talk. And of course, sleep and exercise. And I just want to note that exercise is the rationale for why exercise is so helpful is that it really helps to complete your stress response cycle. So you feel stressed, you have that, kind of heart beating fast, wanting to get more oxygen, your muscles tense, all of that. And then exercise helps you release that fight flight response. And then you feel calm and it engages your parasympathetic nervous system, your rest and digest. So that is part of why exercise helps to decrease anxiety and including many other health benefits. And then if there is any need for safety planning, and then if it is more in the moderate to severe range, then you can think about both psychotherapy and medication. So in general, most SSRIs have a similar level of efficacy, and how you choose which one is really based on past response, on side effect profiles. Like it was suggested in this e-consult that, Zoloft tends to be a little bit more calming and with less risk of activation if there is really high anxiety. And there are usually 3 to 6 weeks between getting to a therapeutic dose and then seeing improvement. But you may see clinical response earlier than those 3 to 6 weeks. And if there's no improvement at 8 weeks at a reasonable dose, then you should try switching or try augmenting with another agent if there's a partial response. And these are, some common forms. And so all of these come in liquid for those of you who work with kids. That said, it is not the amoxicillin bubblegum flavor or cherry flavor. They don't taste very good. And so just to put in a word of caution, the quantity of liquid that is a reasonable dose is actually very low. So it can be mixed with other things, but it does taste kind of bitter. So just to consider that. And then Celexa actually does also come in an orally dissolving tablet, although it's a little bit hard to get. And then here are some, typical effective doses, and here are the FDA indications for these. And in terms of some clinical pearls, Prozac is great if there's concern for med adherence because the half-life is 4 to 6 days. And so if you miss it for a couple of days, you're not going to notice it, and you can actually just stop it rather than needing to taper it. That's the only one that you can do that with. It may be a little bit more activating or energizing, so that to keep that in mind. And then Zoloft tends to be a little bit more sedating or more calming, and so maybe better to take it at bedtime. And also to consider that there is a mild dopamine blocking effect with Zoloft in particular. So if there are other Zofran or antipsychotic medications that are also being taken, to think about that potential synergy, because you can have dystonic reactions with Zoloft, although it's not common. And then Lexapro is really the main other one that we use that is usually covered by Medicaid or Medi-Cal, and is usually more neutral, and is thought to have less sexual side effects. So here are some suggestions for monitoring. When the black box warning came out, the suggestion was to monitor weekly for the first month. Practically, that's really challenging to do. And so, usually if there's an open-ended invitation to reach out if there are any concerns, I usually see people back in about 2 weeks, and really think about monitoring more closely and having more frequent visits in the first 3 months of starting an SSRI, because that's when you're most likely to see side effects, including concerns for activation. And you want to think about making sure that you have education, getting consent, and having a safety plan in place, and having a clear schedule of visits and expectation. And here are some common side effects. Most of these usually abate and usually self-resolve. GI distress is best addressed by starting at the very lowest possible dose and then going to the lowest effective dose and making sure that it's taken with food. And most teens don't eat breakfast, so we usually try to have them take it with dinner because that tends to be the most reliable meal. I'm not going to go over these, but I do want to briefly cover the suicide risk. So I think we all are familiar with this. In 2004, the FDA issued a black box warning that now includes all antidepressants. And this is applicable in young people up to age 25. And so the bottom line is that the FDA reviewed all of these studies. The risk of suicidal thinking or ideation increased to 3.8% with meds versus 2.2% without, but there were no actual increase in suicides in these studies. And the highest risk for this seems to be in the first 9 days, and then with higher than usual starting doses. And I want to acknowledge that there have been some good questions in the chat. So I'm just going to cover just a little bit more and then save a little time for questions. And I'm happy to stay on a little longer. So here are some clinical pearls. Again, I will share this, but basically, the intention is to feel better, not worse. And I really like to say to families, if you notice anything that is going in the wrong direction, then please reach out before your next visit. I'd rather hear from you than not. And then activation is a really physical side effect that can happen and has these different components to it. And this seems to be more likely and more common in younger kids, and is to be differentiated from bipolar switching, which usually occurs later in treatment. So I'm going to share these with folks, and maybe we'll pause here. So here's some takeaways in terms of thinking about a stepped care approach. And this relates to your question from John McKenzie. E-consult service where in-person services may still not be available. And is the e-consult the right service to augment a lack of services? So this is a common and really important question. And I think that I'm not remembering, John, which state you're from. But basically, e-consults are meant to be on this continuum of care and not meant to be a complete replacement for no care. That said, I don't want to, be Pollyanna about the current state of access to mental health providers, because it's been a really challenging problem and it's only been made worse through the pandemic. And so, but there should be in-person care available, even though the wait may be longer than usual. And whether someone has commercial insurance, there are a number of different statewide programs that have direct access to care through telehealth and that do accept insurance. And I can share, some resources to that effect. But LifeStance is a company that is across the US in many states now and offers telehealth. And then for Medicaid or Medicare, the state is obligated contractually to be able to offer some kind of care that is covered by insurance. So what often can happen is that through e-consults or through, some type of consultation, this can support the patient getting started on something and while they're waiting on a wait list. And so this also relates to Libby's earlier question. We really would welcome dialogue back and forth. It doesn't have to be a one and done kind of consultation, because, even in presenting the first case, a lot of people had really great questions and thoughts that they would want to know more about. And so, this can be something that is a little bit iterative and serves as a bridge until you can get into that specialty care. And are there medical appropriateness guidelines for behavioral health e-consults and the tools providers can tap into to build better e-consults? I'm going to defer these to the Confer Med folks.
Actually, for sake of timing, I think, Petra, we will make sure to send these tools to this group, since between Confer Med and e-consult work group, we have some of those tools for Denise.
Great. Other thoughts or questions?
Just to clarify, it looks like Denise was wondering, Petra, if there are clinical tools, like do you have any sort of guidelines of what's an appropriate question, or what should be included as primary care provider sends a question to you? Is there anything like that?
Great. So there's there are basically things that look a little bit like a psychiatric intake that can be really helpful, but there are also approaches, to just having kind of, what's your question? I mean, that's the most important thing, is really defining your consultation question. And is it around, diagnosis? Is it around treatment planning? Is it around medication management, or thinking about other resources? It's important to just try and define, what is it that I'm hoping for? And then thinking back to that slide that we looked at, what is practical, what is possible, what is the family ready to do, or the adult, if it's an adult, and thinking about how does that fit in with your consultation question, and making sure that you are, within, maybe just stretched up to the extent of your comfort zone, but that you are doing, this within your comfort zone. So it's not meant to, make you prescribe an antipsychotic if you're not comfortable doing that. Certain questions come with standard testing evaluations. So, I mean, we as consultants like to have, information. If you have that, that's great, but it's absolutely not necessary. I think, the big things that we like to know are what are the current symptoms, what are safety concerns, if any, danger to self, danger to others, and then what services might already be in place. It was very helpful to know for that first case that he already had a therapist, because that allows for more leverage in terms of what can be done.
So Petra, with that, as we have just a minute left, if there are any final questions that we may not get, you can please enter them in the chat, and we'll make sure to coordinate with Dr. Steinbuchel and get those answers for you. And I have included the link to our survey at the end here, but as you're wrapping up, Dr. Steinbuchel, anything you'd like to leave us with?
I just look forward to partnering with you and hearing from you. I think that this can be a wonderful tool to help expand access to care. We know that mental health conditions are so prevalent, and that you are already seeing these patients anyway. So my hope is that through developing relationship, through getting to know one another, that you'll think about consulting us.
Thank you so much, Dr. Steinbuchel. And please do visit econsultworkgroup.com. Those of you in California, you may have run across the program that Dr. Steinbuchel leads through Children's Hospital Oakland. If you'd like to learn more about that, please reach out and we can share that with you. Once again, if you're a provider and you'd like to receive CME credit, please do click on this link here. We'll also send it to you by email so you can fill out the survey and receive your CMEs. Thanks again for your time this evening, and a special thanks to Dr. Steinbuchel for giving us your dinner hour. Thanks again.